In this third module of the Infant Health Foundation presentations on infant oral feeding, I will address the deterrents or factors unrelated to infants' own feeding abilities that can affect their overall feeding performance. These deterrents will specifically pertain to infants' clinical status, their environment, their behavioral states, and their organization. All of these can play a determining role in how well infants will make use of their own feeding skills. So let's start with the clinical status, which I know you are familiar with, but this is meant to be a reminder. While baby is feeding, what is his color? Pink, he's adequately oxygenated. Dusky, she's inadequately oxygenated, and if oral feeding is maintained, O2 desaturation, apnea, and bradycardia may ensue. Be careful. Blue, around mucous membranes such as eyelids, mouth, lips, tongue, the baby is hypoxic. Feeding must stop. Let baby recover by himself or intervene. You do not have to wait until alarms come on. Remember that oral feeding is recommended if the respiratory rate is below 60 breaths per minute. In our last module, we did a simple math calculation. If the baby breathes once per second and has a prolonged swallow, he may not have sufficient time to breathe between sucking and swallowing to maintain good oxygenation over the duration of his feeding. Heart rate ought to remain between 120 to 160 beats per minute. But it is important to know what your baby's heart rate baseline is. Setting heart rate alarms at 85 beats per minute may not be appropriate if she normally maintains a 90 beats per minute at rest. The baby's environment. This table contrasts the milieu inside versus outside the womb in terms of light, sound, touch, temperature, and mobility of the fetus versus that of the newborn. In regards to light, it is dark in the womb, bright outside. Thus, caregivers should think about the brightness surrounding the baby. Would dimming lights be appropriate? Isolate covers can help. Sound. Sounds are muffled in mommy's tummy, but outside, particularly if alarms go off. Can we speak more softly and make an effort to reduce the surrounding noise level? Developmental care practices aim at maintaining sound levels in NICUs below 75 decibel. Touch. Inside the womb, surrounded by the amniotic fluid, tactile stimuli are smooth, calming, and sustained. Outside, the newborn experiences impersonal, even aversive contacts such as diaper change, heel stick for blood samples. Temperature. Whereas the fetus finds himself in a stable and warm environment at 37 degrees C, the newborn who cannot yet thermoregulate may find himself in fluctuating temperatures in the NICU. Mobility. Inside the womb, the fetus is subjected to continuous maternal input in a fluid environment that supports a flexed position. In contrast, the newborn receives limited maternal input, finds himself in a dry environment, and often in an unsupported extended posture. Taking all these varying environmental changes into consideration, it is not surprising that some newborn infants have difficulty adapting to their new environment. Infants' behavioral states. As part of a newborn individualized developmental care and assessment program, or NIDCAP, Heidi Alls defines 6 states within which infants fluctuate. State 1 relates to deep sleep, seldom seen in the preterm infant. State 2, light sleep. State 3, the drowsy or alert inactive state. State 4, the quiet awake and or alert state. State 5, the active awake and aroused state. State 6, the highly aroused, agitated, upset, and or crying state. Studies have recommended that states 3, 4, and 5 are the optimal states for oral feeding. It is of interest to note that in preterm infants, these states can fluctuate rapidly within seconds. As such, during a feeding session lasting 20 minutes, they may not demonstrate a consistent behavioral state that favors oral feeding. The last deterrent I will discuss is the baby's organization. A number of health professionals not familiar with infant oral feeding do not quite grasp what is meant by organization. In contrast, feeding therapists and nurses do, as they are the ones directly involved with oral feeding. When we say that an infant is organized or disorganized, we talk about his or her overall appearance. For instance, here are some examples of organization. The baby looks calm, relaxed. His posture is flexed, arms folded in midline. He makes eye contact, and his breathing is regular. If an infant is disorganized, you may see some of the following signs. He's agitated, tensed, arches, avoids eye contact, grimaces. His hands may be splayed open, tongue is protruding, nasal flaring, as the baby on the left. His arms are outstretched. There is increased head-limb agitation. Infant's organization can change readily and is observed during feeding. Therefore, when feeding an infant, it is important to watch them. Because a baby cannot speak, he can still communicate with you if you watch him. For instance, if he is ready to feed, watch for some of these cues. Eyes may be open or closed. He is responsive to light touch. He looks at your face. His hands are towards his mouth. He is rooting or sucking. His motor movements are smooth. He is calm and quiet. On the other hand, if he is not ready or need to stop feeding, these are some of the cues that you may see. Staring or gaze aversion, panic or worried look. He cannot wake up, excessive yawning, tremor, startling, spitting up, gagging or gasping, frantic, arching, arms extended, fingers played, color changes, increased respiratory rate, and vital instability. Changes in behavioral states or organization may be due to different reasons. However, if oral feeding is maintained, this baby can demonstrate the same symptoms under different situations, making difficult the identification of the real cause. For this reason, it is important to watch a baby feed, as the earliest symptoms can assist in identifying the origin of the problem. I want to give you 3 examples of what I'm talking about. Let's say our baby, while feeding, is getting tired. In other words, he has poor endurance. Some signs of fatigue would be poor tone, state changes, for instance, sleep, shut down, lengthy sucking pauses, feeding duration greater than 20 minutes, increased milk leakage, drooling, increased respiratory rate. If you continue his feeding, he will likely experience O2 desaturation, apnea, or bradycardia, which would make you stop the feeding. Here is a second example. Presume our baby has poor coordination for sucking, swallowing, and respiration. These are some of the signs of incoordination that you may see. Coughing, choking, aspiration, poor self-pacing, O2 desaturation, apnea, and or bradycardia, oral feeding aversion. Here is my third example. With reflux, you may see the following: choking, coughing, aspiration, arching, emesis, esophagitis, oral feeding aversion. So what you are seeing here is that with these three conditions, infants demonstrate a number of similar symptoms. As shown in these two tables, they can consist of physiological as well as behavioral responses. So if caregivers do not watch their babies closely as feeding progresses, they will miss the early signs that would help them determine what the babies are going through. By the time the serious clinical signs appear, they would not know what the initial triggering factors were. In the previous module, I mentioned how readiness to feed is difficult to define, as it is a continuously changing condition. So due to the difficulty in assessing readiness to oral feed, I would like to propose a different approach. Namely, instead of basing readiness on the baby's age, how safely and successfully we think they feed, we could do the following. Besides ensuring that adequate weight gain is attained, as per our own practice, for instance 10 to 15 grams per kilogram per day, we can assess safety with common sense, i.e. minimal or absence of O2 desaturation, apneas, or bradycardia, and define success not in terms of the completion of the feeding, regardless of how that was achieved, but rather to define success on the basis of the development of good feeding skills. This would imply willingness to give time to babies to develop good skills. I mean that if they are struggling to complete a feeding, stop and to feed the remaining volume. In the long run, oral feeding should be a pleasant, nurturing experience in order to minimize feeding aversion. The next module will address what I call the breastfeeding challenge. Indeed, oral feeding relates not only to bottle feeding, but very importantly to breastfeeding. The latter is of the utmost importance as it provides the optimal nutrition, i.e. mother's milk, along with the optimal nurturing that an infant can experience. So I hope you will be interested in this topic and join me. Thank you for sharing your time.